Welcome, everybody. Thanks so much for joining us. We'll give it a couple more seconds or minutes, perhaps, for some more folks to jump on the call. But thank you so much for being here and spending your afternoon with us. Thanks again, folks, for jumping on the call. I still see our participant number climbing, so I'll give it just a little bit more time before we get started and let folks get a chance to jump on the call. All right, so I guess I will go ahead and get started. Hello, everybody. Thank you so much for joining us this afternoon to discuss a very important topic, healthcare equity at the end of life. My name is Heather Pope. My pronouns are she, her, hers. I'm joining you from Philadelphia, Pennsylvania, where I work as a Northeast campaign organizer with Compassion and Choices. I'm excited to be leading our presentation today, and I'll be starting us off with just a few logistical items. You'll be able to use the chat feature throughout this webinar to communicate with each other and interact with some of the questions that I ask you as a group. If you have a question about the content of our presentation or want more information about a particular subject, you can type in the Q&A box. We have staff members working behind the scenes to monitor this inbox who will respond to your questions and share resources. Lastly, this presentation is being recorded. So if you find yourself wanting to revisit this information in the future, that recording will be sent to you at the email address you used to register for this presentation. With those announcements out of the way, let's get into the content and discuss healthcare equity at the end of life. Okay, so who are we and what makes us qualified to be discussing this topic? Compassion and Choices' mission is to improve care, expand options, and empower everyone to chart their own end-of-life journey. Compassion and Choices believes in person-directed care, where the person is in charge of making their own healthcare decisions. Also, that people should be fully informed and supported by their doctors and medical team on the full range of end-of-life options. It is a core part of our mission to reduce healthcare disparities at the end of life. And I'm excited to dive deeper into this important topic with you today. Next slide, please. So why is this topic something that's important? Everyone should have equal access to the full range of end-of-life care options. Racially and ethnically diverse communities, LGBTQ+ communities, and those with disabilities face systemic and persistent inequities in end-of-life healthcare that mean they are less likely to have the information necessary to be fully empowered to have a death consistent with their values and priorities. We can't address this issue without understanding first where it comes from and how it manifests in the lives of many Americans every day. This makes it our responsibility to care and to see that everyone has access to the same quality options at the end of life. Next slide, please. So we are going to dive a little bit deeper into some of the inequities that exist. The graph you see now on your screen shows a percentage of adults who have their end-of-life wishes documented, broken down by race. As you can see, 35% of white Americans have their end-of-life wishes documented. That is more than twice the rate of Black Americans who have their preferences documented at a rate of 15%. The Latino population documents their wishes at a rate of less than 1/3 of the white population, falling at only 11%. Documenting end-of-life wishes is something that's beneficial for all of us. So in a perfect world, these percentages would not only all be higher, but they would all be the same. Next slide, please. We know too that white patients make up an overwhelming majority of hospice patients. 76% of all hospice patients are white. A pattern emerges that people of color are not participating in end-of-life care services and planning as much as white people are. We know that these things are beneficial to everyone, so there must be some barriers to access. Next slide, please. As compared to white peers, African American patients are more likely to have their pain underestimated, more likely to have their pain undertreated, and less likely to receive opioid medications. Anti-Black racism and drug use stigma result in fewer Black people being prescribed opioids. Unfounded fears of drug abuse lead to more suffering for Black people who sincerely need this type of medication. Next slide, please. The graph on your screen now, while a little bit more complex to read, shows how often Black patients and white patients are given invasive treatments at the end of life, and how Black lives are continually devalued as the patient visits the emergency room and carries out hospital stays at the end of life. As you can see, across the board, Black patients are more likely to receive invasive medical procedures at the end of life. Next slide, please. And lastly, a recent study in Oregon has found that transgender and gender non-binary people are discriminated against even after death when the gender line on their death certificate is filled out incorrectly. This particular study found that more than half of trans and non-binary people had incorrect gender markers on their death certificate. Furthermore, the researchers detail how those barriers continue to harm people who already experience increased health risks and disparities compared to cisgender people. Next slide, please. So who is the most impacted by these healthcare disparities at the end of life and across the board? Black Americans, Hispanic and Latino Americans, Asian American, Native Hawaiian, and Pacific Islanders, Native Americans, as well as members of the LGBTQ+ community. And it's important to note too that inequities may also exist among other communities, and they certainly do. Other communities that may be impacted by healthcare disparities at the end of life can include people with disabilities, immigrants, or people who are incarcerated. Next slide, please. So why do these inequities exist? I'd like you to take a second, if we could go to the last slide, please. Take a second to consider this question on your own. Why do these inequities exist? And message that answer in the chat. So why do you think race and gender identity go so far to determine the level and quality of care that people will receive at the end of life? Consider that for a second and message your thoughts in the chat. Okay, I'm seeing lack of insurance. That's definitely a big one. Historical lag, mistrust of providers, absolutely. Cultural beliefs or a lack of education about end of life. Implicit bias exists and carries over to the end of life. The system is designed for white, heterosexual, cisgender men, absolutely. Prejudice, these are all really great answers. Thank you so much for taking a second to think and share. If you have more thoughts that pop in your head as we continue to move through this presentation, please feel free to message them in the chat. But we're going to move on to the next slide. The inequities historically underserved communities face throughout life continue as they approach the end of life. The conditions in the places we live, we learn, where we work and play, affect a wide range of health and quality of life outcomes. We've identified 5 key factors leading to healthcare inequities, and we'll go over each of them in the coming slides. Those include inaccessible socioeconomic resources, geography, system and provider discrimination and bias, lack of evidence-based cultural competency, and lastly, provider-patient race and ethnicity discordance. Next slide, please. All right, so the first of these factors leading to disparities is inaccessible socioeconomic resources. And somebody who messaged in the chat earlier got it exactly right. That means things like being unable to secure health insurance or afford care services like hospice care. Next slide, please. Geography can play a part, including things like no palliative care service being around where somebody lives. And also there are areas within the United States that get very poor to no internet access, which makes telehealth services unavailable for them. Next slide. System and provider discrimination and bias means things like the presence of systemic racism in medicine and past violence that has entailed. In the United States, our systems and major institutions have harmed and continue harming the people that they're intended to serve. We don't have to look way back in history to see instances of when our healthcare system and our legal systems have forcibly treated immigrants, refugees, Black and brown people, or used people as experiments without their knowledge or consent. A lifetime of discrimination and harm leads to a deep fear, a very valid fear of personal harm at the end of life. Next slide, please. Fourth, lack of evidence-based cultural competency, which mean things like language and cultural barriers being left unaddressed. Care teams are not adequately trained to serve diverse groups of patients, especially not with the sensitivity and self-awareness to begin healing racial distrust of healthcare providers and systems. Providers must approach each interaction with cultural humility, rather than using a one-size-fits-all approach with patients. And when I refer to cultural humility, this is what I mean. A commitment to lifelong learning and self-reflection. The recognition that our understanding of other cultures is a never-ending journey and not a final destination that we will someday reach. It also requires that healthcare providers recognize and mitigate the power imbalance that exists within their systems and how they manifest in the relationships that they have with patients. We know from experts that many professionals and patients are uncomfortable and avoid talking about dying and death. This uncomfortability and avoidance only increases in the presence of cultural differences. And actually, believe it or not, it is not required, nor is it standard practice for most healthcare professionals to receive training for serving patients as they are dying or caring for them through their death. Next slide, please. And lastly, provider, patient, race, and ethnicity discordance. Providers often don't look like the patients and loved ones that they serve. White people benefit from privilege and more access to the resources that it takes to become a doctor or become a medical professional of some type. For that reason, there are less providers of color, which can cause a disconnect with patients given their valid racial distrust in the medical system. According to data from the Association of American Medical Colleges, 56% of all active physicians in the US are white. Next slide, please. So what can we do to improve current end-of-life healthcare disparities? As we go on to the next slide, we'll see that a big factor in this is actually giving the time and attention to study this issue fully. Next slide, please. Thank you so much. In order to best address this problem, our organization knew that there needed to be a deeper analysis done. Experts convened at Compassion and Choice's Addressing Inequities in End-of-Life Planning and Care Summit, which took place on November 4th, 2021. The summit included 14 experts who responded to research about inequities in end-of-life care and planning. Experts included palliative care, hospice, primary care and emergency department practitioners, and advocates focused on addressing healthcare-related inequities, ending systemic racism and discrimination, and providing end-of-life support for LGBTQ+ communities. As participants talked with Compassion and Choices senior leadership and staff about inequities within the communities they serve, they identified promising policy approaches to address these inequities. I'll share some of those solutions with you now. Next slide, please. So what are some of the things that we can do to improve current end-of-life care disparities? Well, first, informing and empowering all communities' awareness of the full breadth of legal end-of-life care options, as well as the importance of advanced care planning so they can make informed care decisions. This includes things like starting end-of-life care conversations with patients and their loved ones earlier, before a time of crisis happens, with repeated discussions over time. It also includes creating opportunities for community-oriented end-of-life conversations. We can be increasing provider and staff education and training on end-of-life planning and care, including helping to build skills on how to recognize and interrupt implicit bias, and increasing one's understanding of patient communication needs, including the meaning of suffering for the patient that they're serving. Next slide. Further, we can develop more high-quality intervention studies that address racial and ethnic-related health disparities in palliative care, so we can see and understand the full scope of this issue for what it is. Increase efforts to recruit and retain diverse candidates into medical and nursing schools and other supportive practitioner programs. That way, more patients can feel comforted that their care team looks like they do. Develop funding solutions for those that don't have insurance or the means to afford hospice care, because everyone deserves to receive the care they want at the end of life, regardless of their financial standing. And creating clear opportunities and incentives to support and uplift end-of-life education and training programs that are integrated across different medical disciplines, so that medical professionals across the board are more familiar with how to meet the needs of patients during the end of life. Next slide, please. Compassion and Choices relies on dedicated leaders and advisors to coordinate our outreach and to shape our messaging and direction. We look to the expertise of multiple leadership councils who represent some of the marginalized identities we discussed today, who are most impacted by end-of-life healthcare disparities. That includes our African American Leadership Council, our Asian American, Native Hawaiian, and Pacific Islander Leadership Council, our Latino Leadership Council, and our LGBTQ+ Leadership Council. These experts help to ensure our materials are culturally relevant and appropriate. They help us build trusting relationships and so much more. Next slide, please. The video that we featured here highlights one of our such in-house experts. This is Brandy Alexander. I'll let Brandy introduce herself and speak a little bit further about her own experience and what our community engagement work looks like at Compassion and Choices.
Compassion and Choices has countless resources to really help with not only end-of-life planning, but conversations around end-of-life planning. My role is responsible for targeted outreach to the African American community, Latino, faith communities, LGBTQ communities, as well as our Doctors for Dignity program. So I actually joined the organization through a temp agency. It wasn't until really I got to learn about the mission that I kind of fell in love and saw that my community in particular was being impacted by not having these conversations. And about halfway through my tenure in 2011, my father's cancer came out of remission. And it's when it really hit home to me that I had all of this knowledge around these issues, but I hadn't spoken to my own father about what he may have wanted or didn't want. When he declined quickly, he was in a situation where he couldn't speak for himself, and our family was in dissension over it. As his children, we thought he wanted something in particular. His wife thought he wanted something different. And the facts are, none of us knew what it is that he wanted. And so we spent our final days really fighting instead of being able to honor him the way we should have. If this is happening to me, someone who's informed, what must be going on in the rest of our community? And so that's when I found what we found to be true. Our community doesn't talk about it, nor does it prepare. At Compassionate Choices, we have worked with different community groups and community leaders to start having these conversations before a time of crisis, so that we are sort of desensitizing ourselves to the subject of death and taking sort of the fear aspect away from it and the mystery around dying and really planning for it. And so we have created a lot of tools and resources that really can help foster that conversation and really break down those specific issues that you face at end of life. Through our community engagement, we bring this topic up around sort of healthcare discussions, around end of life planning, around even financial planning. All of this really has to do with our legacy and getting our affairs in order. Not only do we see this in our everyday life, but even some of our icons in our community also have been impacted. It's a problem that I think we actually have the control to change if we just have the information. You know, death is just as much of a part of life as living is.
Awesome. Brandy is the best. We are so lucky to be guided by her, and I'm sure, as you can tell, we are in very good hands. If you move on to the next slide, a key takeaway, if you are to bring anything from this presentation, is that people can best access comprehensive end-of-life care when they are educated about options and when they can easily find and afford those options. People need and deserve local, culturally sensitive, and affordable end-of-life care. It is our responsibility to see that no matter who you are, where you live, or who you love, you have access to the same quality options at the end of life. So with that, I'd really like to thank all of you for your time this evening. If you'd like to move on to the next slide, I'd like to thank you all so much for being here and foremost for caring deeply about these issues. As you can see on the screen is my contact information, my cell phone number, and my email. If you have any questions that haven't fully been addressed during this presentation or would like to discuss anything that we talked about today in further detail, feel free to take a picture of the screen to capture my information or write it down. But I want to thank you all so much for your time, and I hope you have a great night. I'll hang out here just to give folks some time to write down my email address and phone number if you have any questions. But I really appreciate all of your time for listening about this really important issue. Thanks.